Well, it's great to see you guys tonight, and thanks for coming out on this Monday evening. I'm one of the neurosurgery professors at the University of Wisconsin, and I specialize in functional neurosurgery, which is primarily involved with the treatment of movement disorders like Parkinson's disease, dystonia, and essential tremor, and also do epilepsy surgery as well for patients that suffer from epilepsy that can't be managed with medications alone. And today's going to be an interactive type of presentation, so I will go through things and present the topics, but if you have a specific question or something you want to know more about, feel free to raise your hand and we can talk it over, or you can come up and ask me at the end of the presentation in person if you want to discuss something in more detail or more depth. All physicians talk about their financial disclosures. I don't have any financial disclosures at this time, which means I don't work for any medical device or drug company at this time, and I don't hold any stock in any of the companies. I did receive some fellowship support from Medtronic, which produces deep brain stimulator devices in the years 2014 until July of 2015. So this is an outline of how the talk's going to go today, but of course if people have questions we can deviate some from this as necessary. So first I'm going to give a brief history of deep brain stimulation and how we got to the point where we are today. And the title of my talk was Deep Brain Stimulation, a Proven Treatment for Movement Disorders. And the reason I give it that title is because there is some confusion about deep brain stimulation in some cases. Some people feel that it's still an experimental therapy or something very new or avant-garde, but it's actually been around for quite a long time now, and a lot of people have deep brain stimulators in place and are having good therapeutic effects from it. So after I talk about the history, I'm going to talk about the big three of movement disorders, which are Parkinson's disease, essential tremor, dystonia, and then I'm going to talk about our specific surgical technique, how we do the surgery at the University of Wisconsin, some of the techniques we use to ensure optimal implantation of these devices. And then I'm going to talk about some future technologies where this type of treatment might go with further technological progress, and then round out with some conclusions. So with regards to history, surgical treatment really began in the middle of the 20th century. So in the 1950s, even in the 1940s, patients were affected by many of the same movement disorders they are today, obviously, such as tremor and Parkinson's disease. And one of the pioneers in the field, which I've pictured here, Irving Cooper, he actually found that if you damaged a specific area of the brain, that people would have improvements in their Parkinson's disease symptoms or improvement in their tremor symptoms. And so this was an interesting fact that you could actually damage a small area of the brain and it would improve some of their symptoms. And so some patients with Parkinson's disease or tremor or dystonia were treated by what we call an ablative procedure. They tried to damage a small area of the brain to alleviate some of the patient's symptoms. Of course, anytime you remove a portion of the brain, there's some risk associated with that because the person may develop some dysfunction and they won't get that function back because you've damaged or removed that portion of the brain. So that diminished some of the interest in these ablative therapies, but what also diminished the interest in surgery was the introduction of levodopa. So really in the 60s, they started to figure out that if you gave patients with Parkinson's disease levodopa compounds, it would improve many of their symptoms. And this was a pretty miraculous thing when it initially occurred. There's actually a movie called Awakenings. I don't know if anybody here has ever seen it with Robin Williams. It's about how they, obviously it's Hollywood, but it's about how this medication helped a lot of patients initially, and it was kind of a miracle thing. So the introduction of levodopa initially diminished the interest in surgery. But in the 1980s and 1990s, two scientists working at Johns Hopkins and at Emory, they developed a model of Parkinson's disease in small primates. And they were able to study this primate model, and they were able to figure out the pathways that we've shown here on the slide. And you obviously don't have to memorize these pathways. There's not a test at the end. But what I'm trying to emphasize from this slide is that in the 1980s, there was all of a sudden people understood Parkinson's disease much better, as well as some other illnesses, because they were looking at animal models of what caused these illnesses. And then in the late 80s, early 90s, a man in Grenoble, France, named Professor Benabide discovered that if you did high-frequency stimulation of an area of the brain, it was as though you had effectively removed that portion of the brain. But if you turned off that electrical stimulation, the brain started to function just as it had before. So it was as though you could temporarily remove a portion of the brain. And they discovered you could do that with electricity. Benabide really discovered that high-frequency electrical stimulation creates a temporary reversible lesion effect. So this was a good thing, because that was the problem with the ablative procedures that they'd introduced for Parkinson's disease before, is that if the lesion wasn't in exactly the right place, the person may have some side effects, and those side effects wouldn't go away. But if you put a wire in a place and you stimulate it with electricity, if it helped the patient's symptoms, good. If it didn't help the symptoms and it caused side effects, you could turn it off or adjust the stimulation to a different area, and their side effects would go away. So really, the science of understanding the disease better by the scientists DeLong and Bergman, and then also the science of using this high-frequency stimulation, these ideas coming from France, they came together and were able to produce new and effective treatments for Parkinson's disease and many other movement disorders. And it helped usher in the era of deep brain stimulation. So now, 14 years ago, the FDA approved deep brain stimulation for Parkinson's disease. So the usual targets for Parkinson's disease are the subthalamic nucleus, which is here more centrally, or the globus pallidus, which is here more laterally. So the ideal candidates that we treat Parkinson's disease with deep brain stimulation are candidates that respond to levodopa, and they have what we call idiopathic Parkinson's disease. So patients that have other types of Parkinsonian symptoms that are not levodopa responsive, things like corticobasal degeneration, multisystems atrophy, some of these other Parkinson's mimicking syndromes, they don't respond to deep brain stimulation as well as what we call idiopathic Parkinson's disease that is levodopa responsive. So what can we help with deep brain stimulation? We can help what can we help and what can't we help with deep brain stimulation? So deep brain stimulation doesn't help gait. So if you're having problems with gait freezing or walking problems, deep brain stimulation usually does not improve the balance problems and walking problems that come with Parkinson's disease. And that's unfortunately a thing that's very disappointing for many Parkinson's disease patients, because often people with Parkinson's disease suffer from frequent falls and problems with their balance and stability. Sort of the one caveat to that statement is sometimes when people are on their Parkinson's medicines, they feel that they can walk much more quickly than when they're off their medicines. If that's the case, then sometimes they may have some of that same effect from deep brain stimulation. But in general, we tell patients that deep brain stimulation is not going to help your walking or your balance. It also doesn't help with cognitive problems. So some people with Parkinson's disease will have slowing of their thought processes and other problems with their cognition. And deep brain stimulation doesn't improve that. And it also doesn't help depression. So some people with Parkinson's disease suffer from depression. If the depression is situational in the sense that the deep brain stimulation improved your overall function, then your depression may improve, but it doesn't help depression in and of itself. So what does DBS help when it comes to Parkinson's disease? So when I talk to patients in the office, I tell them, first of all, deep brain stimulation doesn't cure Parkinson's disease. like many things in medicine, deep brain stimulation is not going to make things perfect. It's not going to make things like new again. But what it can do is it can mitigate and decrease some of the symptoms of Parkinson's disease. And one of the ways it does that is by increasing what we call on time. So back whenever they initially developed levodopa therapies, it was like a miracle because when people started taking it, they started feeling better. But with time, people that take levodopa for their Parkinson's disease often have the medicine starts to wear off sooner and sooner and sooner until they're almost taking levodopa all the time. I even see patients sometimes that are taking medicine 6 times a day, 8 times a day, because it doesn't last as long as it used to. And additionally, the medicine is sort of too much or too little. So it's like they're moving around too much and they're really on their medicine, or they're frozen up. So it's too much or too little. So one of my mentors that I trained with, the way he would explain it to patients is whenever you are having a lot of these on and off periods from your medicines with Parkinson's disease, these fluctuations, there's some optimum that you want to be at, but you're sort of overshooting it and then you're undershooting it. So you're moving too much or moving too little. But what DBS can do is it can sort of dampen out this curve to where you spend more of your time close to your optimum medication state. And in general, the studies have shown that deep brain stimulation tends to reduce the amount of levodopa that a person needs by about 1/3. So they can reduce their Sinemet dosing by about 1/3 sometimes, either in terms of spacing that out or taking a total of 1/3 less. It also decreases bradykinesia and rigidity. This is a big thing for many patients. And it improves dyskinesia. So if they're having medication-related dyskinesias, if you can get this curve dampened out where they're not too on and too off, then the DBS will help with their dyskinesia. Yes?
Could you please once again define bradykinesia and dyskinesia?
Absolutely, yeah, thank you for bringing that up. So bradykinesia means you're moving too slow. So kinesia is like movement, kinetics or movement. So so some people have heard of bradycardia, so bradykinesia is moving too slow. Dyskinesia, means out of sorts or incorrect. So if you have for example, this is probably a bad term to use, but if a person is disabled, they have a decrease or a difference in their ability compared to other people. So dyskinesia is basically you're having movements that you don't want to have, is what I would describe a dyskinesia as. So these people are having movements that they don't intend to have. A good example is Michael J. Fox. I don't know if anybody here has seen Michael J. Fox on television. Sometimes it depends on where he's at in his medication dosing cycle, but sometimes he has a lot of dyskinesias in some of his interviews. So his head will be moving side to side, his arms, sort of all his movements are exaggerated. That's a good point, though. If I bring up any terms and anybody wants me to define them, just let me know. Oh, and I forgot to mention one of the things that many people ask about is deep brain stimulation effectively treats tremor for patients with Parkinson's disease. So patients with Parkinson's disease, a substantial number of them suffer from tremor, and this tremor itself is very bothersome to them and disabling to them. And deep brain stimulation does a very good job of treating that tremor. And that's important because that is one of the symptoms that often does not get better with levodopa compounds or Sinemet, for example. They can say, Sinemet helps me in many ways, but it doesn't help my tremor. It never helps my tremor. But deep brain stimulation actually can help tremor, even if Sinemet doesn't. Like I said, Sinemet, if it doesn't help the bradykinesia, if it doesn't help the slowness of movement, or if it doesn't help rigidity, then a lot of times deep brain stimulation will not either. But when it comes to tremor, deep brain stimulation is good at helping that, even if the Sinemet doesn't work for a person's tremor. So that's an important point. One of the great things about working in a field with stimulation technologies is we can do, as physicians, we can do very good studies on stimulation technologies. So deep brain stimulation is easy to study compared to many other types of surgery. And the reason for that is because you can eliminate, you can basically randomize patients in studies. I'm not involved in any studies or doing any studies at this time, but when studies were done in the past, you can randomize patients to have the DBS either turned on or turned off. And you don't necessarily tell the patient if it's on or off if they're in a study. And you can see then how effective the DBS is if you're a scientist trying to study this. And so in the past, when they were still trying to determine how helpful DBS was or how effective it was, they did a lot of different studies. So they did 6 randomized controlled trials that supported DBS, meaning the patients that were randomized to having it turned on did better than the patients that were randomized to having it left in the off position. And of course, just from an ethics standpoint, all the patients that were randomized to having it turned off eventually were allowed to cross over to the on group. So it's not as though they didn't receive that therapy. And also, anytime I bring up a study, since I work at a university, sometimes people, they think that just because they go to a university, they're going to be involved in a study or that we're always doing a study. But that's not always true. We do just standard medical care as well. We do offer some studies, but no one would be in a study unless we specifically asked them and got their permission and filled out extensive paperwork, et cetera. And as I said, right now I'm not doing any studies that are related to deep brain stimulation at this time. So after having that little segue, I'm going to go back to talking about how these studies showed that patients with deep brain stimulation were helped. Yes. Oh, I'm sorry. I didn't see you there, sir. So the question is, correct me if I'm wrong, if the tremor is controlled by levodopa, should the patient still consider deep brain stimulation? Is that the question? It would depend on, for that question, I would have the patient meet with their neurologist and see how the control is. So first of all, are the tremors controlled by levodopa, but you have to take the medication every 3 hours, and you even have to wake up in the night to take it, and things like that, then that person may still want to consider either medication changes or even consider deep brain stimulation at some point. But in general, deep brain stimulation, we usually reserve it for people that are having symptoms that are not controlled with medication. And so one of my favorite things about these studies is they show that it not only did DBS improve motor function, but it also statistically improved quality of life. So believe it or not, scientists that are studying medical procedures and illnesses, they actually have an index for quality of life, and they can look at a variety of factors and try to see overall, is your life better or is your life worse before or after the therapy? And in these 6 randomized controlled trials, people's lives were better after the DBS than they were before the DBS, and that takes into account a lot of different factors. It increased the amount of on time. In other words, the amount of time the patients felt they were close to their optimum medication level, it increased the amount of on time by about 4.6 hours per day. Yes, sir. I do not. I do not offhand. I'm sorry. What percentage? So his question is what percentage of improvement did the 4.6 hours of additional on time represent? But I don't know that statistic offhand. So that's the Parkinson's disease segment of the talk. So I've given quite a bit of attention to the illness of Parkinson's disease now, and we can go back to that and cover that more if anybody has other questions as we go through. But now I'm going to talk about tremor some, because I mentioned that there were 3 different illnesses that I wanted to talk about today that are pretty common and are treated with DBS, and those are Parkinson's disease, tremor, and dystonia. So essential tremor, believe it or not, DBS was actually approved to treat essential tremor before it was approved to treat Parkinson's disease. And that was actually back in 1997, so now almost 20 years ago. Patients that have familial, or what we call essential tremor, usually respond well to this therapy. So often, not always, some patients have essential tremor, they have no one else in their family that has it, but oftentimes when people have tremor, they can usually think of other family members that are affected by tremor as well. It improves tremor that is medication refractory. That's one of the frustrating things about essential tremor is for many patients with essential tremor, medications don't control it significantly, or if they do control their tremor, they cause a lot of side effects like sedation. The target is the VIM nucleus of the thalamus. So these are MRIs. They're projecting a little bit dark here, but this is a coronal cut through the brain like this. And here's the deep brain stimulator lead going to sort of a central part of the brain, which is called the VIM nucleus of the thalamus. So first off, similar to Parkinson's disease, let's talk about what it doesn't help. So DBS doesn't cure tremor, so it doesn't make it go away altogether, and it may not eliminate all tremor, but it improves it substantially. Sometimes tremor worsens with aging, so tremor, like many things, can be progressive as we get older. And just to clarify once again, I'm talking specifically about essential tremor right now, not the tremor that's associated with Parkinson's disease. I'm talking about just the separate illness of essential tremor. Vocal and head tremor can be difficult to eliminate. And sometimes patients that are treated with deep brain stimulation for essential tremor can have some dysarthria or slurring of speech. We can usually improve that slurring of speech or dysarthria some with different programming settings, but sometimes we can't eliminate all of the dysarthria. Similar to deep brain stimulation for Parkinson's disease, we found in randomized controlled trials that this technology is very helpful for people. The randomized controlled trials done for essential tremor showed that there was an improvement in the ability to perform activities of daily living, such as feeding oneself, writing, doing self-care. Also, they noted about a 70 to 80% improvement in handwriting, which is pretty substantial for patients with suffering from essential tremor. Anybody want to ask any questions about essential tremor before we go on? How do I describe what? So essential tremor is often an inherited illness, not always, but often an inherited illness. And one of the main characteristics of essential tremor is that it's what we call postural or action related. So often patients with Parkinson's disease will have tremor mostly when they're at rest. So if they're sitting quietly watching TV or something, their hands will move and shake. But if you say, hey, can you hand me the salt shaker? They will reach and grab it and hand it to you. They don't have the tremor. Now that's different from patients with essential tremor. They can be sitting there at rest and quietly, and they may not have any tremor, but you can say, can you hand me the salt shaker? And they'll reach for the salt shaker, and as they bring it to you, it's very hard for them to hold it without it shaking abruptly. So the tremors are different. So a Parkinson's type tremor is usually more at rest, and essential tremor is usually more with action or activity. But obviously I'm simplifying things some here and there. We have several neurologists at UW that only study movement disorders because there's all kinds of subtle differences between tremor, Parkinson's disease. There's overlap. There's some patients that have both tremor and essential tremor and Parkinson's disease, believe it or not. Some patients have both. And there's many subtleties. But that's a basic description. Any other questions about essential tremor before we go on? I feel like I gave a lot of attention to Parkinson's disease, and then I went very quickly through essential tremor. Postural, or postural, like having good posture, Postur, AL, postural tremor, or action-related tremor, some people also call it. Sometimes people also refer to it as intention tremor. So those are all intention tremor, correct. And those are all terms that people commonly use to describe essential tremor. Another thing that people often notice with essential tremor is they notice that it improves with alcohol. So if they drink some alcohol, they notice that it improves their tremor, which is not necessarily the case with resting type tremor that occurs with Parkinson's disease. So that's another thing that some people notice. Yes. Oh, sorry. Yes, sir. So their question is are there medications for essential tremor? That's a good question. I also want to clarify that basically before somebody is considered for treatment with deep brain stimulation, we always want to make sure that we're not able to help their illness with medication. So there are several first-line medications available for essential tremor. Some of those include primidone, which is one medication we use for essential tremor, propranolol, which is also a beta blocker, which some people use for heart or headache-related issues, but it also helps essential tremor. Other medications sometimes used include Topamax, or known by its generic name, topiramate. And then finally, some people use benzodiazepines, or medications like Klonopin, also known as clonazepam. And those medications activate some of the same receptors that are activated by alcohol, actually. But some of those medications have side effects. Some people can tolerate the medications and some cannot. But but usually people start off with medications first to treat either their Parkinson's disease or essential tremor before they move on to considering treatment with deep brain stimulation. Yes, sir. How many have both? Ooh, that's a good question, Nancy. What would you say? I would say less than 5%. Less than 5%. It does exist, but I'd say less than 5% of the time. It's tricky though, because sometimes patients are seen early in their illness, and believe it or not, sometimes it can be difficult to tell if somebody has essential tremor or Parkinson's disease, because both patients can have tremors, right? But the type of tremor they have is different. And even though I said, well, Parkinson's disease is resting tremor and essential tremor is action tremor, or also called postural tremor, it's really not that simple. Sometimes there's what we call overflow, and some patients with essential tremor will have tremor when they're at rest, and some patients with Parkinson's disease will have trouble doing certain activities due to their tremor. So there is some overlap, but in general, it's not, I'd say it's less than 5%. Yes, ma'am. That's sort of a same, I would also say around 5% or less. But what happens is sometimes early on people think, oh, that person has Parkinson's disease, whenever eventually it becomes clear that they didn't have Parkinson's disease, they have essential tremor. So they got diagnosed with Parkinson's disease, and that was, perhaps not the right diagnosis, and then the diagnosis was further refined or narrowed down to Parkinson's disease. So I know that sounds a little frustrating to people that, hey, how could you get the diagnosis wrong? But sometimes when it's very early on in a person's illness, you may not be able to clearly tell from their symptoms which illness they have. Yes, ma'am.
What criterion are actually used to determine when a patient may be allowed to have treatment?
Yes. Okay, I'll repeat it. Sorry about that. So the question was, what are the criterion we use to determine when a patient would be allowed or would desire a DBS? Correct? So it's complex. We have to look at a lot of different factors. We have to take into account, are they able to get control with medication, as you asked? How much is their illness impairing their life? Because obviously we don't want to do surgery on someone if they're not having a lot of problems from it. We also have to ask, is the person healthy enough to tolerate surgery? Are they, do they have a serious heart problem, or do they have serious, they have other problems that would make surgery too dangerous? And because this is such a complicated question, we really bring together a team of several different people. The neurologist, and Nancy's with the neurology team, they often lead the efforts of making this decision initially, because they're seeing the patients initially for medication management and diagnosis. But then if they feel that somebody needs deep brain stimulation because their activities are very impaired and they're not being well treated with medication, they will usually have them come to my clinic. They'll also be seen by a physical therapist. They'll be seen by a neuropsychologist that does some memory testing and other types of tests on them. And we take all that data together, the neurologist exam, my exam, the information from the physical therapist, the information from the neuropsychologist, and we put all that together and we discuss it in a conference with a neurosurgeon, which is myself there, the neurology team there, and then also the physical therapist and the rest of the, and a representative from neuropsychology there, and we try to have a discussion about what we think would be the best role for the person. But in terms of guidelines, we look at what's called the United Parkinson's Disease Scale, or UPDRS rating scale. We see how responsive they are to Cinemet, either by having them evaluated by the physical therapist or by discussions with the neurologist. And then we check their overall health, how they function on their memory testing and other tests. And we distill all that together, that along with the patient's own desires and goals and wishes, and from there we make a choice. Obviously in conjunction with the patient, we make a choice of what we think would be right, and then we bring the patient back to clinic and talk to them and see what their thoughts are. So it's a complicated process. And I will actually go into our workup some a little bit later in the talk as well. So I'll go back over that, like what our steps are again. That's a good question. Was there other question over here that I missed? So we've talked about essential tremor. So now I'm going to talk about dystonia. Dystonia is, yes?
Okay, you're just going to define it.
Dystonia, I'm going to define. So so dystonia is difficult to define in many ways. So dystonia is unwanted movements or muscle contractions, and it can be either segmental, which means the patient only has certain muscles affected. For example, head turning or torticollis is one type of dystonia that's called a segmental dystonia. Some patients can have a generalized dystonia where basically throughout their body they have movements, contractions of muscles that are unintended and often that are opposing one another. For example, if you bend your arm, the bicep will contract and the tricep will relax. But in some patients with dystonia, for whatever reason, those movements are not coordinated. So even if they try to bend their arm, the bicep will be contracting, but the tricep will contract as well. So they can't make a normal coordinated movement. And a lot of times dystonia can have a significant component of pain as well, because it's so, because these muscles are fighting each other and they're staying flexed or contracted longer than they should. That leads to quite a bit of pain. And one time I had a patient in my office with dystonia who told me, he said, have you ever had a Charlie horse? I don't know if you guys have ever heard the term Charlie horse, like you have that contraction in your calf and when you're getting ready to go to sleep and it really hurts. He's like, whenever I have dystonia, it was like he had generalized dystonia. He said it was like I had a Charlie horse all over my body all the time. It was the way he described it. He said it was very painful to him in his back, in his shoulders often. So it was really, can be a really hard disease. So dystonia got a FDA humanitarian device exemption in 2003. And dystonia is not as common as tremor or Parkinson's disease, but there still are a fair number of patients that have it. And we generally reserve DBS for dystonia for patients that have failed medical therapy, just as we do for Parkinson's disease and essential tremor. And with dystonia, for example, if a person has head turning that they can't control, Botox might be a good option for them, and Botox is often used for treatment of dystonia. So that's one of the medical options. Some patients, and these are even more rare, have what is called a primary dystonia, or a genetically inherited dystonia, often with the DYT1 or DYT6 genotypes, meaning they have these types of genes, and it causes them to have a generalized dystonia throughout their body, often that presents early in life. Torticollis or head turning is another type of dystonia. That's a segmental dystonia. Generally for dystonia, we treat the more lateral target is the one we consider initially for dystonia, which is the globus pallidus. But if that one cannot be used for some reason, you could also consider using the subthalamic nucleus. And dystonia, just like this is a theme you'll hear today, basically DBS doesn't cure any of these illnesses, it improves them. It improves the symptoms. So DBS doesn't cure dystonia. Sometimes symptoms of dystonia progress despite using DBS and despite other types of therapy. People have worsening of the illness as they get older, just as they can with tremor and Parkinson's disease. And some patients have what's called a secondary generalized dystonia. Some of the patients that are most affected by this illness, for example, are patients that have cerebral palsy, can have a prominent secondary generalized dystonia. And for secondary generalized dystonia, meaning a non-inherited form of generalized dystonia, DBS may not be as effective as it is for segmental dystonia, like head turning, or for an inherited primary dystonia, like DYT1 or DYT6 genotypes. And a lot of patients with dystonia may suffer from problems with swallowing or their speech, and sometimes deep brain stimulation doesn't help as much with those symptoms as it does with other symptoms of dystonia. So DBS does help a lot of things for patients that have dystonia, and these include, and these have also been studied in randomized controlled trials, and they showed that DBS for dystonia improves activities of daily living, improves quality of life. Another interesting thing about deep brain stimulation for dystonia is with tremor and also with Parkinson's disease, you will often see an immediate change in the patient's symptoms when you turn the device on or turn the device off. But for dystonia, sometimes you may have to have the device turned on for a period of time before they start to have improvement in their symptoms. So it's not immediate. It takes time of the device being left on to modulate that brain circuit. And they've also found that if patients are implanted when they're younger, if they have dystonia and they get the implant when they're younger, they may have some improved outcomes. So this harkens back to your question. Oh, yes, sir. Yes, sir.
I have dystonia symptoms after
Yes.
taking my Cinematic.
Okay, that's very common. That's very common. So his question was, is he has, well, I guess, did I cut you off before you asked your question? You just asked how common it was. So his question was, is he has symptoms of dystonia after he takes his Cinemet for Parkinson's disease? And I was going to say, yes, that is very common. That is one of the, sometimes people will have dystonia associated with their Parkinson's disease, and often it occurs after when they're in a medicated state. So that is very common. So that is actually one of the things, deep brain stimulation in some cases can improve those symptoms because it can change the way you medicate yourself. It may cause you to need less medication and may, obviously I'm not speaking specifically for your case, I don't know specifically your case, but in general it can help people sometimes with dystonic symptoms from their Parkinson's disease because it can change the amount of levodopa medications they need and how those need to be administered. So sometimes it can help. But, so that's a good question. And sometimes these, so back to the preoperative evaluation, this goes back to your question, how do we determine who should undergo deep brain stimulation for these illnesses? So first of all, it really all starts in the neurology movement disorders clinic. Patients may see an outside neurologist from outside the UW system that has an expertise in movement disorders, or their outside neurologist may refer them to UW, and that's where the evaluation begins, and that would be confirming the diagnosis, making sure they have, essential tremor or Parkinson's disease or dystonia versus some other type of illness. And then once they've decided, once the neurology team has decided that they have one of these illnesses that is amenable to treatment with deep brain stimulation, and that the patient's symptoms are not well controlled with medication, they may ask the patient if they are interested in deep brain stimulation. If they are interested in deep brain stimulation, we start some tests to see how helpful this could be to them. One of the things we do is we have them tested in the neuropsychology clinic. This is to test their memory and also to look for any problems that they have with depression or other types of issues that are good to know about prior to going into the DBS process. And it's important for me to say for the neuropsychology testing, a lot of people get nervous about the neuropsychology testing because it's not, they think that, well, if I fail this test, I won't be able to have this therapy or something like that. But that's not really the way the test is used. Really, the way it's used is to see sort of where the patients could potentially have problems and what their strengths are and how we can use those strengths and potential problem areas to get them through the process in the best way possible. That's really more of what it ends up being usually. And then we have them seen by physical therapy, where they may do on and off testing with Cinemet, depending on what the patient's symptoms are like. And they'll also evaluate their tremor and see how much their tremor is impairing their activities of daily living. They may have you do things like pour water from one cup to another, try to eat with a fork, try to draw a spiral, some of these basic tasks. And then they will see me in clinic during this process, and I can talk to them about what the risks are for deep brain stimulation and what the expectations could be like. So how do we do the placement? We do the placement in the operating room. It's usually done with IV pain medication and some numbing medicine on the top of the head. And then we place some small recording electrodes down into the area of the brain. I'll be talking to the patient as well as the other team members throughout the surgery to make sure they're comfortable, but also to test the electrical stimulation we're giving to make sure that it's effective and it's helping some of their symptoms. And this is what some of the intraoperative neurophysiology looks like. We can see the recordings of the brain cells to make sure that we're getting the microelectrode into the correct spot. How am I doing on time? It's getting ready to slow down here. And then once we've done that, we can make some trajectories. I'm just trying to hustle through this part a little bit so we can have you guys talk to some patients that have had DBS, because obviously they're the people that can tell you the most about it. And we used to pin patients in a halo type device that held them to the table while we were doing the operation, but now what we found is we use just a little 3D printed frame that sits on top of their head like a hat that actually guides the electrode to the correct spot while we're doing the surgery. And that's just a computer generated image of that device. And initially in the post-op, usually people, after they have the wire placed in the brain, they stay in the hospital about one night following the lead placement. About a week after putting the wire into the brain, we do a battery placement. And this is usually done in the outpatient setting under general anesthesia, so they can be completely asleep for that. Usually they have to modify their activity and do lighter activities for a couple weeks to 4 weeks following the operation. And then we activate the DBS system about a month after the placement of the leads. And programming and maintenance of the system is really key. Yes, ma'am?
I can't picture how much of the brain is exposed when you do this.
We make a little opening that's about the size of a nickel or a dime on top of the head. That's it. So a very small amount of the brain is exposed.
Take out a circle of the skull?
Yes, a very small circle about this. No, we actually put back in some cement to cover up that hole. It's not concrete, though, I promise. It's a bald spot? No, their hair usually grows back there. Unless they had a bald spot before the surgery, then I can't give any guarantee. It's under the scalp. It's in the bone under the scalp. Everything is completely internal and implanted. Yeah. Why don't we, you guys, let's let the patients talk now and let them give you guys their story and their experience. Yeah.
As you can see, there aren't antennas sticking out of their heads, and they don't have wires hanging down their necks, because I think sometimes people have a misconception that this is all something that everybody can see. And I think, I don't know, the man on the end has a problem. But anyway, I think I'm going to just turn it over to them. I've asked them to tell you their story, why they had the surgery in the first place, maybe kind of what led them to make that decision, their diagnosis, what's changed in their life now, maybe that they've had it. And 1, 2, 3 of them all have tremor. And I'm going to guess they'd be kind enough to let me turn them off or turn themselves off and let you see how bad tremor was before they had surgery.
Went on one called a Requip for a while. A side effect of Requip is compulsive gambling. So if anybody's on Requip, has an urge to gamble, talk to your neurologist. Be honest. I had a tremor, started with a little tick in my finger. Then it was 2 fingers, 3 fingers, eventually ended up diagnosed with Parkinson's. When Dr. Dent came in and told me that, I said, okay, I had done my research and figured that's what it was, so I then started looking at options and whatever. Over a period of time, it became worse, and I went and heard about this DBS. In fact, I fished with a guy down in Florida that had Parkinson's, and he was stumbling all over the place and wobbling. And I was out there, and he said, oh, you got Parkinson's? And I said, yeah, how can you tell? He says, well, a tremor. He had the 3rd deep brain stimulation implant at Mayo Clinic 25 years before. And he was going to Michigan to get the other one done because it had gotten infected. But one hand didn't move and the other one was wild. And well, that's a possibility for someone sometime down the road to do it. So for the last few years, I kept asking Dr. Dent, is it time, is it time? Well, a year ago, I was sitting in the audience like you are and saying, is this right for me? And the following week, I had my neurology appointment, and it was decided to start going with it, start the thing. The longest lead time I had was a neuropsych evaluation. If you're thinking about start making an appointment now, because it was supposed to take 3 months. In fact, I was done for a month before I would have gotten in originally. They called me one morning and said, we have a cancellation, can you be here? And I said, I'm there. So I got that done. I started on January 28th with the process that he had with the 3
Hi, Lucy. This is Wendell.
neuropsych, all that stuff. I went through that. The experience itself was interesting. You sit, the most bizarre, well, first of all, they take 4 little screws, little incisions. You go home that night with a little Band-Aid over it that are the anchors for the halo that you get. I asked Dr. Lake, what do they do with those? He says, well, we throw them out. I said, can I get mine? Sure. So I've got my little halo. We're going to use for Halloween costume. But they put those 4 things in. Then you come back, it was a week later, I guess it is. And you sit there, and they get you nice and comfortable because you're going to sit there for 6 to 7 hours. They open it up. You don't feel anything. It's not painful. There's no pain. And then they start planting the electrodes, and you start seeing double. You have tremor or tingling in your fingers, tingling in your toes, speech, whatever it is, and each one of them they make a little tweak and they adjust it. And finally they get it perfect where they want it, and they close it up. You go one night to the hospital or 2 or whatever you want. And then about 3 days later I went in and I had the battery pack put in. They coil up the stuff underneath there, and then they open it up and thread it back. Mine goes on this side because I shoot left-handed, so I didn't want to blast the battery pack away. So I said, put it on the right side. And the electrode goes down to the battery pack, which is right here. The longest month of my life was from February 3rd to March 3rd. And that was the time that I had to wait till they turned it on. And I went into Nancy's office, and they turned it on. And you can turn mine off if you want. Huh? I don't have I didn't bring my thing. I'm a bad boy. She's always got the magical turnaround. And it was the longest month to wait until it was time to turn it on. Uh-oh.
You said so.
And one thing, I get to tweak it once in a while. So I get to play with it. I can turn it off if I really want to and really see it going. But it'll take a minute. The thing that I found is it was the biggest life changer that I've ever had. Because now suddenly I can tie my own fish hooks on. I can eat soup again. Where else can you, Dr. Lake is a miracle worker. 9 o'clock, 9 o'clock at night when I was home, he called me at home from wherever he was to check on me. I mean, how many people have ever had a doctor, let alone a surgeon, call you late at night to check on you to see how you're doing? I'm trying to think if there's any other things that are covering.
Sometimes when you turn batteries on or off, it is instantaneous. It's just taking a little bit, but
Yeah, this is the hand that really
you
goes.
gotta leave it down because it's at rest then.
Yeah, but it's a game changer. I mean, it changed my life completely because I still have the balance and tremor or other issues, but okay, turn it back on.
I don't like it
I don't like it off. And but it was an experience. I mean, to sit there and say I see four.
Okay, so actually, that was being nervous. This is actually off now. Sorry.
Okay.
That's why it took so long.
Yeah. That guy right there, yes, sir.
Does it get worse the longer it's off?
Does it get worse the longer it's off? It'll keep tremoring like it used to. I never turn it off. It would probably go to the point that it would the tremor get worse if I left it off for a long time? And I think it probably would be to the point where it would have been had I not had it, but I never turned mine off. Yeah, that's what it was doing beforehand. Was it doing that beforehand? The thing is, the one comment I would have is they should have put Velcro in over the battery pack, because in 3 to 5 years they're going to have to change it. So either a zipper or Velcro would have worked nicely to make that easier.
Hi, I'm Dave. I had dystonia starting in '92 with a little tick in my neck. Did Botox for 16 years, became immune to the Botox, so it no longer worked. Then finally in 2008, I had the DBS. And since no complications at all, I've had 2 batteries replaced. Now I have a rechargeable. But it's a wonderful, wonderful thing. It put me back to where I was. Now, when she turns it off, there'd be no telling when it would go back. I mean, it could be a long, long time. It's different from yours, where yours immediate. Mine, it could be days before anything happened. Yeah, mine started out as torticollis, and then my head would go like this constantly. I would never stop. Then it turned into cervical, where my head would go up, and I couldn't bring it down. So I'd constantly staring into the sky. And that's what the DBS improved on. And it took a little while to adjust the settings, but once Nancy got the right setting, it was immediate. And it's been this way since 2008. I thought. Yeah, I was just looking straight up. Yeah, and I couldn't bring the head down. It was impossible to bring the head down unless I brought it down. Now, when I went to sleep, it would improve, but once I woke back up, it would go right back. And I was awake for the whole time and talking to the doctors. You know, it was fascinating. Yes, sir. What's he trying to say, Nancy?
Hello. Anyway, well, my question was, yours was constant moving.
Yes.
Mine is spirit off and on. So I just wondered if that was what I had too.
But he has Parkinson's, correct?
Yeah.
That'd be better for you to answer. He has Parkinson's.
I can't hear the question.
Want to repeat the
What was the question? Or Nancy?
He's saying that his head moves back and forth like that, but I think we've got two different types of, like a head tremor, which is like this, whereas Dave's like motion back and forth, I think was partly the dystonia. When Dr. Lake was talking about how, muscles in one group move one way, that's kind of happens in people's necks sometimes, what we call it cervical dystonia, when your head pulls one direction and you want it to go the other direction, and there's kind of a tremor as your head struggles with going back and forth. And I think what he's describing is different than what a head tremor might be for someone else.
Well, my name is Chris, and I have a central tremor. Whereas I might be the youngest person on the panel. I'm 45 right now, but I've always had an essential tremor. So as long as I can remember, so I've had it for over 40 years. And imagine with a severe tremor, and it was pretty bad in high school, where just what can happen to somebody who has a tremor, you know. I could never hold liquids in my left hand ever, and my right hand was probably my best hand, but that was still pretty bad. And it wasn't until I originally in '96 started to look into it, because I started a family, and I was concerned about whether I'd leave it to my kids and find out it was hereditary. And I don't know what they called it back then, but there was this, I think it was a 13-syllable word that they told me that no way I could remember. So, but I just, it was just something I dealt with. There was always tricks that I could do. Whenever I wrote, I had to anchor myself. I bartended for 6 years, so I never really let it become an issue. But about 2 years ago, it started to get bad. It was to the point where it was simple things. It was like I had to drink with a cover on my liquids out of a straw. So I was probably the only 40-some-year man that was drinking out of a sippy cup. And it was progressively getting worse. And it was to the point where we go to any dinners that my wife would have to carry my stuff for me. It was not fun. So I started to look into it, and it was a long process. And basically, it's pretty bad when you can't even shave yourself. I had to use 2 hands to shave myself. Something like scratching my nose became clawing my face. So it was pretty bad. And I went through. I didn't want to take any medications initially, but when it got to a point, I was left with no choice. I had to take medications, but the problem with the medication is I got none of the benefits and all the side effects. And actually, one of them, I can't remember the name of it. I had to stop taking it because within probably a couple hours after it, my brain went into a fog. And I work with a bunch of engineers, so it was the point where I couldn't think. So I decided to pursue the path, and in April I had the surgery done. So, and it was immediate. So as soon as Nancy turned it on, it was immediate. But you know, it was pretty much we they say pouring water. I have to laugh at that because everybody was getting a shower. If you were within 10 feet of me, you were getting wet. So you want me to turn it off?
Well, let's pour water now.
Okay.
Put your hands out this way.
As you notice, I still have a little bit of a tremor, but the left hand, and I'm going to turn it off in a minute, and with mine, there's a little bit of a latency, but you'll tell after a couple minutes how bad it gets. So I'll just go ahead and turn it off. And it's actually really simple to turn on and off. So that wasn't that was the least of my worries, but and this gets really bad. So it's for me, it got to the point where I felt completely helpless at times. But and my wife's still getting used to not having to do everything, have to carry things for me, but I got, and it was kind of cool because shortly after they turned the battery pack on, I was able to finally fill ice cube trays. It may not seem like a big deal, but I'd never been able to do that, so for me it was huge. So. If I go to drink, so, see. But there was one advantage to having the tremor, because I have nieces and nephews and my kids, because I could get my leg to shake without even trying, so I could bounce them for hours. So.
Curious as to how you felt when you were in high school and how the other kids reacted to the way you had to deal with this shakiness back then.
I fought a lot. You develop a really tough skin when, it was everything. I've heard been called, been told everything, by younger and older. You toughen up pretty quick when people hand you like cartons of milk and say, "Here, make me a milkshake." And it was always, speech class in high school, when you're sitting there holding note cards and you can't even, it was just easier to memorize things because I literally couldn't, it was all the time. So, yeah, it was not a fun experience, but it toughens you up pretty quick.
Did you find that in your family that there's been a history of that?
Yep. My mom has it. My younger brother has it. My older brother has it. And my sister all have it. But between my younger brother and I, we are by far the worst in the family.
Has anyone else in your family, if I may ask, had the same kind of treatment you have?
Nope, I was a guinea pig.
Thank you. I admire your courage to get through that basically.
Guess I was thinking, you said you're how old, I forget.
I'm 45.
And I think a lot of times people think DBS is waiting until you're 60 or 70 and you can't stand it anymore. I think we've had some 40-year-olds because it so significantly affects their life.
Yeah.
And we have actually done 80-some-year-old Dr. Lake. I can't remember.
Oldest patient so far is 82 that we've done. So, but you know, every patient's different. I think our youngest patient that I've done is 29. I think I did a 29-year-old with essential. Yeah, he's 29. The old.
Oh,
the,
yes,
the
he was not
youngest-
even 30 years old.
Yeah, the youngest patient I did, and he actually works in healthcare. So, he is the youngest patient I've done. Of course, I've heard of children actually having it, but that's, you know, for different illnesses. But really depends on each patient's situation and what they think can help them the most. And everybody's experience is different, just as you're hearing from them. So it's very valuable to hear from the patients because everybody's experience is different.
But I'm just going to turn it on real quick. Come on. That's probably a little nerves, but the other hand is we're pretty steady, so.
I was just wondering if you have noticed any symptoms in your children already.
Yes, I have. My 13-year-old has it almost as bad as I had it.
Are you going to have DBS for him or her?
I have 5 boys, so they're on.
Okay.
Isn't anything that I've talked to him about yet. It's going to be his decision. Right now he handles it, but there will probably come a time that, you know, that he'll have to have it. For me, being in my, last couple of years, it's gotten worse, and, I was told it was going to progress, and it had been. So if I hit my 50s and 60s, I couldn't imagine going on, just being able to handle that as bad as it was now. Because, I always joked, I always said there's 2 things I could never do growing up. And one was to be a brain surgeon, the other was to be still.
About 3 years ago, I'm getting ready to have a new battery pack put in. My battery pack only lasted so long because my settings were so high. None of the medications that I took worked at all. I'm doing just fine. I mean, I have no tremor at all whatsoever. I'm on no medications at all. But now if I turn it off, I'll shake like a leaf. I had mine done due to the fact that I had a daughter. She was just to be born, and Nancy started talking to me about DBS. And I've been going to see Nancy for 9 years. Yeah. And it's just progressively gotten worse to the point where the medication wasn't doing anything at all. I'm one of the lucky few that the Requip and all the other medications that they have didn't affect it at all. So then it finally got to the point where it got so bad that I was like, it's time. And within about 6 months of talking to Nancy and Dr. Dent, I ended up having the surgery, and I had what they call MRI guided surgery, where I was completely put out, but I was put out for 13 hours. And this is the one that Dr. Lake was telling you about, that they actually screw your head to the table, which got to be uncomfortable when they woke me up, but that's neither here nor there. Other than that, I'm doing fine. I was a welder, a certified welder, they don't say that that has a whole lot to do with it, but I have a feeling some of the toxic fumes that I ingested, it's not for certain. And I was a hellion when I was a kid, to be on the safe side. I guess I could say it that way. I had stopped counting concussions at the age of 10 when I couldn't reach any more fingers and toes on my feet. I mean, I had probably about 20 concussions by the time I was 15. Sure.
He has leg tremor too, which you can see coming up from the floor there.
And I don't know if most of the guys can detest or testify to this, but when you hear that click that goes off, that beep, 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 that's normally not a very friendly sign. It normally means that the battery pack's going off and you're going to feel it very shortly, which Nancy has a tendency to do and not tell anybody about.
She's mean, isn't she? But
Yes.
You get a little card that says you don't have to go through the thing. And you get these guys saying, oh, this one's okay, this one's okay. I said, I haven't ever heard one, I'm not going to risk it. They say one's okay. The one's the magnetometer and the other one's the one that sweeps around. They said, oh, that's okay. I said, not for me, I'm getting a pat down. And they give you, they give you a pat down. But I'm not going to risk going through one of those things. I've flown a few times. Yeah. I said, I don't want to be tremoring the whole rest of the trip. So, The other thing is insurance-wise. When I sat out there last year, I said, is this covered by insurance or Medicare? I just turned 67, so I would have been 66. And the answer was yes. And between Medicare and my supplemental, which I paid a few $100s in deductibles, but for the most part, it was all covered. So check with your insurance. I met with one guy that was thinking about it, that Nancy had me talk to, and he was going to be 60. He was going to go on Medicare in November, but he had it scheduled for October. And I said, I don't want to be advised, but you may want to wait till November, till you turn 65, and you get on Medicare before, just not to get caught in a trap. Talk about a big donut hole.
Just going to say one thing that made the whole process a lot easier, other than the fact that it's a great medical staff at the UW. I've seen a lot of doctors, but it was comforting to know that you go from one department to the other, and they had nothing but the highest respect for each other, and it really made it all. It was a much more comforting feel. I'd say without this, it helps to have a good support system when you're going through the process, because for the first week, for me to walk, 100 yards took everything I had. So my mother-in-law always joked it was like the first time in her life somebody actually walked slower than her. So, but just having your family there, having somebody there that because it's not gonna be the easiest on your family initially, because it's brain surgery. You're gonna be tired. You're gonna be wore out for a while, and with when I had it and I was in the hospital, I was planning on staying 3 or 4 days, but they came to me at like 6 in the morning and said, "You're going home today." And I think it had a lot to do with I'm not a very good patient and I don't like lying around very long. 4 o'clock in the morning, I was ready to get up and go for a walk. So it was, I think they were afraid I was going to drive them crazy. Yep.
Yes, thank you. This is a question really for Dr. Lake and or Nancy. How does the effectiveness of DBS change over time as Parkinson's disease progresses?
I usually tell patients to make it, to somewhat simplify it, is that DBS will make you as good as you can be, but how good each of us can be may decrease as we get older, if that makes sense. So in other words, let's say when you're 60, your tremor is like this, and DBS improves it by 70%, so it's like that. If when you're 80, then your tremor's like this, and the DBS improves it by 70%, it may be like this. So it always provides some improvement. It's just that as the disease progresses, more symptoms may come through. But every patient is different, and one of the really rewarding things I've gotten to do, in addition to take care of new patients I've met, is also to take care of patients that have been running around for 14, 16 years that are still doing well. Actually I replaced a battery on someone who had their essential tremor treated, who was 90. So they were 90 and they got a battery replacement, and it's really still helping their tremor a lot. That's essential tremor, so that's a different illness than you were talking about as Parkinson's disease. But it also helps the symptoms of Parkinson's disease and has a durable effect. But a lot of these illnesses are progressive as we get older, meaning that the symptoms do get worse as we get older. And how quickly they progress depends on each patient. Some patients progress quickly, and then I've seen other patients, I'm sure Nancy has too, that have had Parkinson's disease for 40 years. So they've had some progression, but obviously they're able to keep on going on and doing some of the things that they like to do and doing what they want to do.
I think what makes a big difference too for people is if we can get people more active, if tremor is disabling people or rigidity is disabling people, and you can get people back moving again, and they're able to golf or exercise, walk again that they couldn't do very well before, I think that really does amazing things for their symptoms. As Dr. Lake said, it doesn't cure. Unfortunately, disease progresses on. The nice thing about DBS, though, too, is so if we program each of these people and have settings that are doing a wonderful job of controlling symptoms, and that it gets worse over time, as I call it, we tweak them. Then you maybe have to turn something up a little bit or change the settings a little bit and can make a big difference. But as Dr. Lake said, I have patients who surgeries were done back in 2002 and still have amazing benefits from DBS. I think there's information out there that says DBS is only effective for 2 years or 5 years or whatever. It makes a huge difference. And maybe, and I'll use Mike as my example here, who was able to stop all of his medications, maybe 5 years from now, he's going to need something. I also have Parkinson's patients who take a lot of medications or still take their carbidopa, levodopa, but don't have the side effects because we've gotten rid of all the dyskinesias. So it's just so individual.